So, very good evening to all. On behalf of SIG Dermatopathology, I welcome you all to today's sixth in the series of quiz-based teaching session on histopathology of vasculitis and vasculopathy. So, I'm sure you have had wonderful previous lectures on various reaction patterns and basics of dermatopathology, and this would also be a good learning experience for you all. So this is being done under the aegis of IEDVL EC, the IEDVL Academy and SIG Dermatopathology, and also the Dermatopathology Society of India. So stay tuned and happy learning to all of you. So I would now like to hand over to Dr. Sasi for his talk.
Hello, everybody. Welcome. So you can see the screen, hopefully. So please do log into Kahoot. Thank you, Dr. Geeti, for the kind introduction. I'll just load my presentation. For some reason, that's just a second. Just load that up. Technical issue. Okay. Okay. Can you see my presentation, everybody? Technical team?
Yes, it's visible.
Yeah, thank you. Thank you. So, right, let's start off. So this basically today's lecture is on histopathology of vasculitis and vasculopathies. So this is, as usual, a quiz-based lecture, and as we've been doing for the last many quizzes, the Kahoot rules remain the same. So I'm not going to go through them in many great detail because all of you hopefully are familiar with it. But essentially, please log on to kahoot.in. And I've already shown you the game pin, which is this here. Oops, a second. So hopefully everybody can see the game pin here. As a game pin visible, 4080716. Is it visible? Is the Kahoot screen visible?
Yes.
Yes, sir. Yes, sir. Yes, sir.
Yes, Dr. Sasi, it's visible.
Okay, fine. So you need to log in and enter the Kahoot pin, and you'll be in. Include your full name, including surname for identification, please, if you want to win the prize. And as with previous quizzes, the time for each question would vary based on the difficulty of that question. And once attempted, we cannot go back. Each question is marked out of 1,000 points. And the quicker you get the right answer, the more points you score. Wrong points or not attempting gets you 0 points. No negative marking. Okay. So let's move on to the lecture. So the architecture of skin vasculature, I think we'll need to just briefly go about it. Before I go ahead, I'm seeing a few things on my screen, and because I've done a whole desktop share, are you seeing all the Zoom links and everything on your podcast as well, or is that not visible? Is it only the PowerPoint presentation that's visible? Because I can see the Zoom tab.
Only the PowerPoint is visible.
That's fine. As long as no disturbance, that's fine. Thank you very much. So the epidermal vasculature, the skin vasculature consists of arteries and veins, the medium-sized ones that lie deep down in the subcutaneous vascular plexus. From there on, you have smaller vessels, the arterioles that go up, the red ones here, and they meet at the deep vascular plexus around the hair and glands. That's where the reticle dermis is. Then from there, you have smaller arterioles going up, and these go and merge into the superficial vascular plexus, from which you have the papillary loops, where you have the capillaries and the postcapillary venules, and these venules join the veins lower down in the dermis. So that's essentially the dermal vasculature. Now, Why is this important? Because the pathology of, the pathology of each type of vasculitis depends on which sort of part of the vasculature is affected. And that's very important for us to understand if we need to understand the vasculitis. So we have 3 Kahoot questions, which are basically basics, which you should know by now. So we've got 3 Kahoot questions in a row. The first question is this. Which of the following are not immune complex mediated diseases? Which of the following are not immune complex mediated diseases? And your options are Hinox-Schwann purpura, weakness granulomatosis, Churg-Strauss syndrome, or hypocomplexemic urticarial vasculitis. Okay, which are not immune complex mediated diseases. So let's go to Kahoot and start the quiz. So this is first question coming up. So you can multi-select. You can select more than 2, 3, or 4 options even. You got 20 seconds. So which of the following are not immune complex mediated diseases? Are not. So you've got 4 options. Only 26 answers so far. Okay. So of the options, Hinox-Schwann purpura and hypocomplementinemic urticarial vasculitis are the ones that are immune complex mediated. Okay. So they are type 3 reactions. Weakness granulomatosis and Churg-Strauss syndrome are ANCA-mediated diseases. Okay. Here, what happens in the pathogenesis is that there are antibodies, cytoplasmic antibodies, which target the neutrophils, and these neutrophils release their toxins, and these damage the vessel walls. And this is the pathogenesis of ANCA-mediated diseases. They are not immune complex mediated. So the right answers in this case are Hinox-Schwann and hypocomplementemic urticarial weakness granulomatosis and Churg-Strauss syndrome, because they are not immune complex mediated diseases. Okay, so some of you have got that right. Let's see what the leaderboard is looking like right now. So we've got Ayush and Abhishek Parekh who got the correct answers, followed by Deepali, Y2K, and Aditi. Excellent. So let's go to the next question. The next question is, which of the following is an essential feature, the absence of which excludes a diagnosis of vasculitis? Which is an essential feature, the absence of which excludes a diagnosis of vasculitis? There's only one right answer. A, fibrinoid necrosis vessel wall. B, inflammatory infiltrates. C, leukocytoclasis. Or D, extravasate RBC. Okay, which of the absence of this excludes a diagnosis of vasculitis? And there's only one right answer. Okay. The absence of this excludes the diagnosis of vasculitis. Let's go to Kahoot now. Oops. There we go. Somebody please follow the chat box in case somebody is having any difficulties, a technical team.
Yes, sir. Yes, sir.
Okay. So which of the following is an essential feature, the absence of which excludes a diagnosis? We've got 9 more seconds. Is it fibrinoid vessel wall necrosis, inflammatory infiltrates, leukocytoclasis, or extravasate RBC? Right. Most of you have gone for fibrinoid vessel wall necrosis. Actually, in early cases of vasculitis, fibrinoid vessel wall necrosis may not be visible, okay, and may be absent. So you don't exclude a diagnosis just because it's not visible, as is obvious from the term vasculitis. Itis is inflammation. So without the presence of inflammatory infiltrates, we do not make a diagnosis of vasculitis. So inflammatory infiltrates have to be present to make a diagnosis of vasculitis. And only 8 of you have got the correct answer. This is a slightly trick question. Let's see how many of you have got it right. So the leaderboard has changed. Fatima Nazir is on top, followed by Anmol, NG18, Induan, Soumya, Narula. Okay, so these are trick questions. These are not easy questions. These are slightly trick questions. Okay, so let's go to the next question. These are all basics, mind you. Which of the following is most essential to make a histological diagnosis of leukocytoclastic vasculitis? Which of the following is most essential to make a histological diagnosis of leukocytoclastic vasculitis, your options being fibrinoid necrosis of the vessel wall, intramural inflammatory infiltrates, leukocytoclasis, and extravascular RBC. There's only one right answer. Similar options, okay, which is essential to make a diagnosis of leukocytoclastic vasculitis, okay? So let's go to Kahoot and see what you think is the correct answer. These are slightly tricky, but once I explain the answer, it'll be easy. So we've got 9 more seconds, 60 answers so far, 61, excellent. Excellent. So 70 answers. So the correct answer is leukocytoclasis, as with the previous question. If you got to make a diagnosis of leukocytoclastic vasculitis, leukocytoclasis has to be present. As I explained, in early cases, fibrinoid and vessel wall necrosis may be absent, okay? But leukocytoclasis has to be present, and that's one of the early features you see in lot of neutrophils and leukocytoclasis in cases of leukocytoclastic vasculitis, okay? So 3 questions down. Let's see what the leaderboard is looking like. It's quickly changing. Abhishek Parekh, followed by Tushar, Y2K, Chana, and Fatima Nazir. Excellent. So let's go on to the lecture now. I think, right, there you go. So the etiological classification of vasculopathies is broadly based on whether it's vasculitic or not. Okay, if it's not vasculitic, then it's either vaso-occlusive or vaso-intrusive. Vaso-occlusive can be thrombotic or embolic. There's no inflammation there primarily. Inflammation can be secondary, but primarily there's no inflammation. Or vaso-intrusive, like in calciphylaxis or amyloid, where there's amyloid which surrounds the vessels. Vasculitic can be either immune-mediated, okay? And immune-mediated can be divided into ANCA or immune complex-mediated. I explained that earlier in the first question. So ANCA is immune-mediated, but not immune complex-mediated. Then you have septic or infective vasculitis, which is also vasculitis because there's inflammation. And then you have lividovasculitis, which is slightly controversial. And I'll explain why, because some textbooks describe lividovasculitis as having no inflammation, and they label it under vasculopathy, under vaso-occlusive. Because I'll explain that later. But Ackerman actually describes lividovasculitis as being a true vasculitis. And I also believe the same based on the limited number of cases I've seen. I think it is sometimes a true vasculitis. I'll explain that later. Okay. So, yeah, and remember, even vasculopathy sometimes in the later stages, once the thrombus forms, there is secondary inflammation. And this secondary inflammation can be sometimes confused with vasculitis. And in some cases, therefore, there is an overlap between vasculitis and vasculopathy. And sometimes the sort of diagnosis is not so clear-cut. So what are the histological criteria of a vasculitis? Apart from inflammation, which should be present, there should be evidence of vascular damage, which is a vessel wall or endothelial cell necrosis or fibrinoid change or perivascular fibrin deposition in chronic cases. There may or may not be intramural inflammatory infiltrate. So there is always inflammation. Without inflammation, you don't call it vasculitis, but intramural inflammation may or may not be present. And yes, with strict criteria, the sensitivity can be very low if you apply these criteria very strictly. And as I've explained, sometimes in early cases, you don't see vessel wall damage in the form of fibrinoid necrosis. You may just see leukocytoclasis, okay? So the ancillary features are also therefore very important. The most important being carrier excess, nuclear dust, or leukocytoclasis. That's what is leukocytoclasis, wherein you see nuclear dust or carrier excess. Perivenular or an interstitial deposit of fibrin is also a very important clue to the diagnosis of vasculitis, particularly in the later stages when you're not actually seeing inflammation in the vessel wall. Apart from that, extravascular RBC are, of course, a clue, but can be non-specific and can be seen in any acute inflammation. Endothelial swelling can be present, but again, non-specific. Intraluminal thrombosis can be present in any thrombotic disorder. So though it is a feature of vasculitis, it is not specific. Tissue necrosis, of course, because of the vasculitis, there's impediment in blood supply, and that can cause tissue dermal necrosis or sometimes even epidermal necrosis. And because of the necrosis, basement membrane damage, they can maybe reduplication and thickening, and of course, there may or may not be presence of eosinophils. If you have any questions, please do type them in the chat box. We'll answer them at the end. So this is a typical example of leukocytoclastic vasculitis. This is the nuclear dust you can see here. You see not of neutrophil polymorphs here. You can see the polymorphs. Inflammation within the vessel wall may or may not be present. And then you have fibrinoid vessel wall change. You can see the vessel wall is slightly damaged here. So these are the changes you can see here. But here you see almost complete vessel destruction. The vessel itself seems to have been completely destroyed, and the thrombus has become reorganized. In fact, lots of nuclear dust, karyorrhexis, or leukocytoclasis, as we call it, and fibrin within the vessel wall and in the lumen as well. Okay, so and you see lots of extravasate RBCs, of course. Here you're only seeing the fibrinoid vessel wall necrosis without much in the way of thrombosis. And again, nuclear dust is present here. Lots of lymphocytes as well here. So it's a later phase of the disease where neutrophils gradually get replaced by lymphocytes. Here you're seeing a lot of thrombus, extravasate IBC. Here it's probably a later phase because the inflammation is particularly mild. It's not a typical example, but yes, in later phases of the disease, you do see inflammation, not so much inflammation, but fibrinoid vessel wall necrosis and thrombus is present here, and also lots of extravasate IBC. Now, when the necrosis of the vessel and thrombus becomes extensive, you see dermal necrosis and epidermal necrosis as well. Okay. So what are vasculitis? Is a mixed group of disorders characterized by inflammation and necrosis of the vessel walls. They are classified based on the gross appearance and histological alteration of the vasculature, caliber of the affected blood vessels, frequency and involvement of specific organs, and also the associated laboratory anomalies. Okay. So the cutaneous vasculitis, however, classified based primarily on whether it's a small vessel or a large vessel disease. In the skin, there are no large vessels. It's essentially medium vessels, and medium vessels is what we call large vessels in the skin compared to the smaller vessels that are present, which are the arterioles and the capillaries and the postcapillary venules. And sometimes there's also venulitis, and these are all very small, present higher up in the dermis or in the mid dermis, sometimes the deep dermis as well. Okay, so this brings us on to the next question in Kahoot. So the question is, which of the following is not medium vessel vasculitis? So we're going by the book. Which of the following is not a medium vessel vasculitis? Your options are Kawasaki disease, James cell arteritis, polyarteritis nodosa, and Takayasu arteritis. Okay, so your quiz starts now. It's multi-select, so you can choose more than one answer if you want to. It's not essential in a multi-select question to choose more than one answer. Which is not a medium vessel vasculitis. Got 10 more seconds. 5, 4, 3, 2, and 1. Right. Okay, so most of you have got the answer right. So James cell arteritis and Takayasu arteritis are called large vessel vasculitis. Kawasaki and polyarteritis nodosa are the so-called medium vessel vasculitis. Okay, so these two are the right answers. Let's see what the leaderboard is looking like. Pretty much similar, but we've got a few at the bottom. Channa, Shilana, and Soumya Narula have moved up. And up 14 places, Ayush, who's the highest climber. Excellent, well done. So we've got 15 quizzes in total, so 4 down. So the Chapel Hill consensus classification of 2012 is still valid. You've got large vessel vasculitis, and some believe Takayasu and James are a part of the same spectrum. We don't see those in the skin. So the ones highlighted in yellow are the ones that we see in the skin. So we see polyarteritis and Kawasaki, which are medium vessel vasculitis. Of the small vessel vasculitis, we have the ANCA-associated vasculitis. Again, they're very rare in the skin, though we do see them very rarely. I've not highlighted them because they're quite rare, and I've not seen a case so far in the last many years since I've been practicing dermatopathology. I've not seen any cases primarily presenting in the skin. Then you've got the immune complex small vessel vasculitis, of which cryoglomerulonic vasculitis and hypocomplementary urticarial vasculitis are those that are present in the skin, apart from, of course, IgA vasculitis. I forgot to highlight that. Then you have variable vessel vasculitis, where small and large vessels are affected. Example, Behçet's disease. Then you have single organ vasculitis, where you have isolated leukocytoclastic vasculitis, and you have cutaneous PAN, which does not have any systemic implications, has very good prognosis, localized to the skin. Then you have vasculitis associated with systemic disease, and we all know these entities. And then vasculitis associated with probable etiology. This is the consensus, Chapel Hill consensus. That's how they classified it, and that's what I'm showing here. But we all know these drug-associated ANCA, drug-associated immune complex, Hep B, Hep C associated vasculitis, etc. But there are a number of diseases that are not included that are very relevant for us. These include capillaritis, chronic leukocytoclastic vasculitis, of which erythema elevated diatinum and granuloma facial are examples. There's nodular vasculitis or erythema induratum, which is a medium vessel vasculitis. There's thrombophlebitis, again, which is a medium vessel vasculitis. Lymphocytic vasculitis, a controversial entity, but nevertheless exists. And then you have vaso-occlusive diseases and secondary vasculitis, which are not included in the classification. Now, the two main mechanisms of vasculitis, which we discussed already earlier, one is immune-mediated and one is the direct destruction due to infectious pathogens, as in septic vasculitis. Now, of the small vessel vasculitis can again be classified into granulomatous and non-granulomatous. Of the granulomatous, you have granulomatosis with polyangiitis, GPA or venous granulomatosis, where you see collagen degeneration with variable basophilic necrotic lesions surrounded by palisading macrophages. This is what forms the granuloma, okay? And then you have the eosinophilic variant of the same thing. So histologically, if you imagine the same thing with eosinophils, okay, then that is Churg-Strauss syndrome. Both of them don't differ much, apart from the fact that in Churg-Strauss, granulomas may not always be seen. And then you have systemic symptoms like asthma and eosinophilia in Churg-Strauss syndrome. All right. Now, LCV of small vessels without granulomas, you have microscopic polyangiitis. And then you have the classical leukocytoclastic vasculitis, idiopathic and secondary, and then the chronic forms of leukocytoclastic vasculitis. But one of the most important things that hasn't been discussed in books particularly is erythema nodosum. Now, most paniclitis, and I'll discuss this in my paniclitis lecture, most paniclitis are actually vasculopathies. And the primary paniclitis, erythema nodosum and erythema induratum, erythema nodosum is in fact a deep leukocytoclastic vasculitis, where you see leukocytoclastic vasculitis around postcapillary venules of the subcutaneous fat. And in fact, the proof for this is that when you have leukocytoclastic vasculitis that affects the fat, there is often it often goes down the septum, so it's a septal vasculitis when you see leukocytoclastic vasculitis affecting the fat. And clinically, these lesions mimic erythema nodosum. And also erythema nodosum, like lesions in Behçet's, which is a small vessel vasculitis, are similar to erythema nodosum per se. They don't differ either clinically or histologically. So therefore, it is believed that erythema nodosum is in fact a deep leukocytoclastic vasculitis affecting the deep capillaries and postcapillary venules present within the septum. Okay, so that's an example of leukocytoclastic vasculitis affecting the small vessels. So this is a pictorial diagram, not mine, from one of the publications showing small vessel vasculitis, of which include the immune complex mediated diseases and the ANCA mediated diseases. And these affect primarily the arterioles up to the veins. Then you have medium vessel vasculitis affecting, or which can be immune complex mediated or anti-endothelial cell antibody mediated, which is PAN or Kawasaki. But remember, the so-called small vessel vasculitis, which includes HSP, cryoglomerular vasculitis, etc., can affect also the medium vessels. So just because there is medium vessel affection, it does not mean it's a medium vessel vasculitis. The diagnosis of medium vessel vasculitis has to be based on a number of other criteria, which I'll discuss later. So you see here, So even in polyarteritis nodosa, you also have a small vessel vasculitis. So even in polyarteritis nodosa, you have the capillaries being inflamed and arterioles being inflamed. So there is an overlap between these entities, and the diagnosis of medium versus small vessel vasculitis is largely based on clinical symptoms. It's not purely histological. All right, so let us go on to leukocytoclastic vasculitis. Leukocytoclastic vasculitis, otherwise called cutaneous necrotizing venulitis or vasculitis, or also called cutaneous small vessel vasculitis or cutaneous leukocytoclastic angiitis, all mean the same thing. As I've explained earlier, is a type 3 hypersensitivity reaction caused by antigen-antibody complexes. There are various precipitating events, though often it's idiopathic, but can be caused by various infective agents or therapeutic or diagnostic agents. It's a reaction pattern rather than a specific disease, and it can be associated with a number of systemic disorders, as we all know. These are the various manifestations of it as well. You have henoch-Schwann porphyria, acute hemorrhagic edema, arterial vasculitis. We all discussed that earlier. But remember, vasculitis can also be secondary, and we don't call this primarily a vasculitis. This is vasculitis in lymphomatoid papulosis. Here you see fibrin within the vessel wall and thrombosis, and inflammation, of course, which is present in LYP. But this is vascular affection that is secondary to the inflammation present. This is not a primary vasculitis. Okay. So again, we've come back to Kahoot. We've got 3 questions in a row based on what we've discussed partly and your basic knowledge prior to prior to this lecture. So the first question here coming up. So look at this picture. It is a typical case of what is leukocytoclastic vasculitis. I hope you all agree. So the first question in the 3 in a row questions, the first one here, which is true of these options? Shave biopsy is adequate to make a diagnosis in this case. A perilesional biopsy is preferred rather than biopsy from a purpuric papule. The age of the lesion should be more than 48 hours for all the features to develop. So if you're taking a biopsy, take a biopsy from a lesion that is more than 48 hours, which is true. In the case of a deep punched out ulcer, which is not present, but if it is present, in the case of leukocytoclastic vasculitis, a biopsy from the ulcer edge is preferable. Which of these is true? Okay. So I'll give you 2 seconds to make up your mind. Shave biopsy is adequate. Perilesion biopsy is preferred rather than biopsy from a purpuric papule. Age of the lesion should be more than 48 hours. Or in the deep punched out ulcer, take a biopsy from the ulcer edge. Okay. So which of these is true? So let's go to Kahoot. Which of these is true? Only one of them is true. Shave biopsy is adequate. Perilesion biopsy preferred if it's papule. Age of the lesion should be more than 48 hours. Biopsy from ulcer, if deep and punched out, should be from the edge of the lesion. Okay. I've just realized actually, I should have said center of the lesion, but in fact, that of all the options given, that is still the right answer. And most of you have got it right. Shave biopsy is inadequate because if you're doing a shave biopsy, you're missing the deeper vessels. Okay. Perilesion biopsy is not preferred because you're again missing the diagnosis. You should take a biopsy from the actual papule. The age of the lesion should be less than 48 hours. It should not be greater than 48 hours. So based on exclusion, a biopsy from the ulcer, if deep and punched out, should be actually from the middle of the lesion. That is the correct answer. It should not be from the edge. So let's see how many of you have got the right answer. So the leaderboard, Shilana is up to the top, followed by Soumya Nagula, AVI, NG18. Now, because you've got code names, even if you win the quiz, unfortunately, we're not able to give you prizes, AVI and NG18. Payal is 5th. 8 players just hit an answer streak of 3. Excellent. So yeah, this should be ulcer. It should be the base of the ulcer. And I'll explain that later. Okay. Now, next question. There we go. What is the purpose of a biopsy in a clinically typical case of LCV, leukocytoclastic vasculitis, of 1 week duration? Okay. All cases suspect to be vasculitis should have a biopsy. It is essential to confirm the diagnosis. To confirm the diagnosis, basically, that's the purpose. B, there is no need. It is not possible to distinguish various small vessel vasculitis from each other on histopath. So no need to take a biopsy. 3, to predict renal involvement. 4, to differentiate small from medium vessel vasculitis, you need to take a biopsy, even if leukocytoclastic vasculitis is of acute presentation of less than 1 week. Okay. What is the purpose? One of these options is correct. Let's go to Kahoot. Don't want to waste too much time. There we go. We're 30 minutes into the quiz, into the lecture. 6 out of 15 questions are done. So essential to confirm the diagnosis, therefore we do it. There's no need to do a biopsy. To predict renal involvement, to differentiate small from medium vessel vasculitis. So what is the purpose of a biopsy in typical case of LCV less than a week's duration? The right answer is no need. So 21 of you have got it right. And I'll explain that after we finish the next question, okay? Let's see what the leaderboard is like. Soumya Nagala is on top, followed by AVI, Guna Balaji, Dr. Shankar, and Tushar. 9 players have reached an answer streak of 3. Let's go to the next question before I answer this, okay? So next question, 54-year-old male with recurrent crops of lesions since 6 months, okay? So obviously this is a vasculitis. Recurrent crops since 6 months, 54-year-old male. Your options are, which of the following is true? A biopsy is essential in this case to differentiate small from medium vessel vasculitis. Biopsy is not needed as diagnosis is obvious clinically. In the clinical picture shown, a biopsy should be taken from perilesional skin. Okay. A sample for DIF study should also be taken routinely. I think, if I'm not wrong, this is you can choose multiple options. So there may be more than one option that is true, remember, or there may only be one option that is true. So just look at the options properly. Biopsy is essential to differentiate small from medium, not needed. Clinical picture shown, a biopsy is taken from the perilesional skin, and a sample for DIF should also be taken routinely. Okay, this is both testing your clinical knowledge as well as your histopath knowledge. But these are all basics, so I hope you can still answer these. 7 out of 15. Which of the following is true in this case? Biopsy essential, no need for biopsy. Biopsy from perilesional skin, or DIF essential. All right, actually, this is a single answer, sorry. So biopsy is essential is the correct answer because we need to differentiate small from medium vessel. DIF is not essential, and I'll explain that in a second. Obviously, no need for a biopsy is the wrong answer. And biopsy from perilesional skin, again, will not help because you need to biopsy the lesion. If you biopsy the perilesional skin, that will not help. Now, why have I put perilesional skin repeatedly? If it's an ulcer, for example, if you're not talking about vasculitis at all, if you take a biopsy from a venous ulcer or something, and you take a biopsy from the ulcer itself, just because the ulcer, within the ulcer, there's lots of inflammation. And I mentioned earlier, there is secondary vasculitis whenever there is an inflammatory process. So in an ulcer, which has nothing to do with vasculitis, just underneath the ulcer, underneath the erosion, there is often vasculopathy. They can be either just fibrinoid necrosis, livedo-like changes, or there can be a true vasculitis. So unless the vasculitis is extending into the deep dermis or around the ulcer, so if the vasculitis is not just confined to under the ulcer, but to the skin surrounding the ulcer as well, it's obviously visible in a punch. You see the ulcer on top. Often the entire epidermis is not ulcerated. You see a bit of normal skin, which is still preserved. And if you see vasculitis underneath that bit as well, then you know that the vasculitis is primary and not secondary to the inflammation caused by the ulcer. Okay. So let's go to the leaderboard before we discuss the answers. So we've got the leaderboard is pretty much unchanged apart from Maitri Patel, who's gone to the 5th position. So combo breaker 8 players have just dropped the answer streak of 3, unfortunately. Let's see if we need to answer any of these again. So yeah, I've already answered these. In this, in a case of leukocytoclastic vasculitis less than 1 week, often these are self-resolving cases and a biopsy is not indicated. Because A, it's not possible to distinguish between various small vessel vasculitis, and you cannot predict renal involvement, and you don't really need to differentiate small from medium vessel, especially when you don't have any signs of a medium vessel vasculitis in this particular case. But even otherwise, most are self-resolving. So why do you want to do a biopsy unnecessarily? You don't need to confirm the diagnosis always. It's a typical clinical, presentation. So yeah, I put up this picture because this is a case of livido racemosa. Only in this particular case, you want to take a biopsy from the center of the livido. Okay, here the pathology is actually in the middle of the vessel. That's in the middle of the lesion. So here, one of the vessel here has got occluded, leading to a livido-like change surrounding that particular vessel. So only in this particular scenario, you want to take a biopsy from the center of the lesion. Otherwise, in vasculitis, you want to take a biopsy from the lesion itself. Okay. So in likely idiopathic leukocytoclastic vasculitis, most cases self-limiting, no investigation is usually necessary. I often just do a urine dipstick unless recurrent or has systemic symptoms. So biopsy not needed. Usually I do a urine dipstick. If it's negative, then you're done. If it's positive, then you may need to think about systemic affection. So if it's typical, then you may or may not do a biopsy, not essential. But if it's urticaria reading with bruises, if it's caused ulceration, hemorrhagic vesicles, bullae, or livido changes or nodular lesions, then it's suggestive of a medium vessel vasculitis, in which case you may consider a biopsy. So the histology is of two patterns in leukocytoclastic vasculitis. In early lesions, less than 48 hours, often rich in neutrophils. Between 24 to 48 hours, neutrophils regress and get replaced by lymphocytes. So if you take a biopsy after 48 hours, often you don't see the neutrophils, and therefore you may miss the diagnosis of a leukocytoclastic vasculitis. So therefore, biopsy an evolving rather than evolved lesion, papule, vesicle, or nodule rather than a macule. Atrophic lesions, biopsy the center. DIF, if you're doing it, do for a lesional skin, not perilesional again. Take a deep or possible fat, a biopsy that includes a fat to rule out a medium vessel involvement and a paniclitis. And remember, I told you, small vessel vasculitis may coexist with a medium vessel vasculitis, and presence of small vessel vasculitis does not exclude a associated medium vessel vasculitis. Should we routinely do DIF? To be honest, DIF has no role in the diagnosis of vasculitis, especially small vessel or medium vessel vasculitis, because it's positive in about 81% of patients, but highly variable. Early, you can have C3 and IgM. Later, you have fibrinogen and IgG. Late, IgG disappears and you only have C3 and fibrinogen. May be useful in IgA vasculitis or Hinoch-Schönlein purpura. So again, I said maybe because of a particular reason, because it's non-specific in the absence of CPC. LCV with IgA on DF can also be seen cancer-associated vasculitis, venous granulomatosis, and inflammatory bowel disease. In one study, only 24% of patients with vascular IgA deposition had Hinoch-Schönlein purpura. So it's non-specific in the absence of CPC. Okay. So this brings us on to the next question in Kahoot. Let's see what the question is. What is the level of blister in bullous leukocytoclastic vasculitis? Level of blister. Is it intraepidermal? Is it subepidermal? Is it both? Or is it none of the above? Let's see what the answer is. So let's go on to the next question. Question number 8. What's the level of blister in bullous leukocytoclastic vasculitis? Ten more seconds. 9, 8. So those of you who still want to participate in Kahoot and you've joined late, feel free to enter the PIN number. PIN number is in the chat box, so it's visible here at the bottom of the screen. So the correct answer is both. The reason being, the etiology of bullae in leukocytoclastic vasculitis is either dermal necrosis or epidermal necrosis. When the necrosis is primarily epidermal, you can see an intraepidermal bulla. When it's primarily dermal rather, you see a subepidermal bulla. But you can also have both. So the answer, in fact, is both, because there's only one option here. And 11 of you have got it right out of 60 odd or so. So I think the leaderboard may change. Yeah, Shilana is on top, followed by Soumya, AVI, Gunabalaji, and Dr. Shankar. Up 25 places. Excellent is Praveen, who's the highest climber. Right. So this is an example of leukocytoclastic vasculitis. There's vasculitis there in superficial and deep dermis, causing a subepidermal bulla. Actually, you can see that this is the epidermis, and actually there's intraepidermal and it's subepidermal as well. You can hardly see the basal membrane is destroyed, but you can see the basal membrane here. So it's intraepidermal here, but it can also be subepidermal in a number of cases. And this is a vasculitis because in this case, you can see clear-cut vasculitis with fibrinoid change, intramural neutrophils, the eosinophils as well, and nuclear dust here and here. Okay. All right. This brings us on to the next question in Kahoot. Histological features of urticarial vasculitis. Now, you need to know what urticarial vasculitis is. If you don't, you'll know that after this question. I'm not going to tell you that, but being dermatology and pathology PGs, you should know what urticarial vasculitis is. Now, what is true of urticarial vasculitis? A, it is not a true vasculitis. B, it is a lymphocytic vasculitis. C, the histological features are those of leukocytoclastic vasculitis. Or number 4, the presence of marked inflammatory leukocytoclastic vasculitis is against a diagnosis of urticarial vasculitis. Which of these is true? There's only one correct answer if I'm not wrong, but let us see. Let's go to Kahoot and see if it's only one correct answer or there are multiple. Let's see. Yeah, it's multi-select. There can be more than one correct answer. The histological features of urticarial vasculitis. Not a true vasculitis. It's a lymphocytic vasculitis. It's a leukocytoclastic vasculitis, and presence of marked inflammation of the leukocytoclastic type excludes the diagnosis. There can be multiple answers which are true here, but there may only be one answer as well in multi-select. It's not necessary that, right. So, yes, the correct answer is it's a leukocytoclastic vasculitis, and the presence of marked leukocytoclasis does not exclude the diagnosis. It's neither lymphocytic, and yes, it is a true vasculitis. So, there you go. So let's see how many of you have got it right. Right, Shilana, followed by Guna Balaji, Soumya, Maitri Patel, and AVI are at third and fourth and fifth position, respectively, up 12 places, Doc SS. So there are about, I think, 6 more questions to go. So those of you at the bottom can still catch up. Sort of 9, I think most of you, or the top 5, have got 5 correct, because you got about 4,000 odd points, which is more than 50%, but good going, because these are tricky questions. So what is urticarial vasculitis? Urticarial vasculitis essentially means there is vasculitis, there is inflammation, obviously, otherwise you don't call it an itis, and it's of the vessel, okay? But it's called urticarial because clinically the lesions resemble urticaria. Now, why do the lesions resemble urticaria? Because there's marked dermal edema, and that's what makes it look like urticaria. There is red cell extravasation, but it is not significant. That's why you don't see purpura primarily, but once the lesions heal up, they may leave purpuric marks, okay? So urticarial vasculitis is essentially leukocytoclastic vasculitis without much in the way of red blood cell extravasation. The features are subtle. There's marked edema resembling urticaria, and therefore it is called urticarial vasculitis. It resembles urticaria both clinically and histologically, because histologically there is marked dermal edema, but there is also inflammation of the vessels. That's why it is there is leukocytoclasis. You can see here lots of nuclear dust, okay? You're not seeing fibrinoid vessel wall change. And that's why I said it's very subtle. In early cases, even leukocytoclastic vasculitis, you may not see fibrinoid vessel wall change, okay? So that's urticarial vasculitis for you. And the common entity is hypocomplementemic urticarial vasculitis. That's, we've mentioned that earlier briefly. Now, this brings us on to another variant of leukocytoclastic vasculitis called chronic leukocytoclastic vasculitis, of which erythema elevated diatinum and granuloma fasciale are two classical examples. Now, these are difficult cases histologically. Often what we see is a dense mixed infiltrate of lymphocytes, plasma cells, neutrophils, and sometimes eosinophils as well. There's often a Gren zone of papillary dermal sparing, dense infiltrate in the dermis. Then if you look hard enough, you see nuclear dust. And nuclear dust is a clue to the presence of vasculitis here. You may or may not see a fibrinoid vessel wall change, but you often see hemosiderin, which is an indication of there being extravasation of RBC. You're seeing plasma cells here, lots of plasma cells, lymphocytes, sometimes histiocytes may also be present. So it's a mixed infiltrate. In later phase changes, later stages of disease, especially in erythema elevatum diatinum, you see marked fibrosis of the storiform pattern, and that's typical of the late lesions. Okay, this brings us on to the 10th question, I think, in Kahoot. So this is just a true or false question. We'll go on to this quickly. And there's only be 10 seconds for this question on Kahoot. So listen to the question carefully. Inflammation within the vessel wall of a large vessel is pathognomonic of vasculitis of a large vessel, but inflammation within the vessel wall of a small vessel is considered non-specific. Is this true or is this false? The entire sentence, the two parts to the sentence, either of them being false will make the question false. Inflammation within the vessel wall of a large vessel is pathognomonic of vasculitis, but inflammation within the vessel wall of a small vessel is considered non-specific. Think about this. Okay, once we go to Kahoot, there will only be 10 seconds. So let's go. True or false? Okay, so only 29 of you have got the correct answer. By 50-50, at least 50% should have got the right answer. But the correct answer is, in fact, it is actually correct. The whole sentence is correct. And I'll explain that in a second. Let's see what the leaderboard is looking like, if it's changed. Maitri Patel is up to the top, followed by Shalana, Tushar, NG18, and Gunabalaji. Excellent. Now, these questions this time are quite tricky because I had to spend quite a considerable amount of time to think this through. But yes, inflammation within the vessel wall of a large vessel is pathognomonic. Why is it? Because diapedesis, all of you have heard the term diapedesis. Diapedesis refers to the migration of inflammatory cells from within the vessel lumen to the surrounding interstitium. Okay. Now, diapedesis is a normal phenomenon. So it occurs in any inflammatory disease. The inflammatory cells, for them to get from within the vessel wall to the interstitium, have to migrate through the capillary walls. So therefore, these are small vessels, to the capillary and small arterial walls as well, but essentially capillary walls. So when they're migrating, at some point, they will be present within the vessel wall, right? So even in non-specific inflammation, say in, say, psoriasis, say in lichen planus, when there is inflammation in the interstitium, or say granuloma annulari, how does the inflammation get into the interstitium? It has to cross the capillary wall. And therefore, when you take a biopsy, while the inflammatory cell is crossing the vessel wall, you will see inflammation within the vessel wall. So in a small vessel, inflammation within the vessel wall is non-specific. However, diapedesis does not happen in a large vessel. And therefore, if you're seeing inflammation within the vessel wall of a large vessel, that is pathognomonic of vasculitis. Okay, I hope this concept is clear, and I hope you don't forget it now that you've got the option wrong when you took the quiz. One of my tutors in MSIT used to say, please make all your mistakes during the trial questions. We had these weekly exams for MSET long ago. You don't have MSET now, you have NEET. But when we did the weekly test, he used to say, you can make as many mistakes as you want during the trial test, but when you go to the final exam, the MSET, don't make the same mistake. So it's good if you're making mistakes here, because people who make mistakes will will not forget the answer. Okay. So don't worry if you're making mistakes, it's all good. So this is inflammation within the vessel wall of a medium vessel, and this is a true vasculitis. Okay, this brings us on to the next question. I think this is question number 11, actually, if I'm not wrong. Yes. The differentials for septal panniculitis with medium vessel vasculitis include all except. So the differentials for septal panniculitis with medium vessel vasculitis include all except. There's only one correct answer, I think, or maybe there's multiple. I can't remember, but we'll know it when you go to Kahoot. Septal panniculitis with medium vessel vasculitis include all except. Okay. Let's see. Actually, sorry, just a second. It says multiple choice. Include all except. It's a double negative questions. Let me see if I've got the options correct. Include all except. Okay. Actually, please rephrase the question, because in Kahoot I cannot change the answers. Okay. So the question should read, of the following options, which of these is not an example of septal panniculitis with medium vessel vasculitis? Okay. Which of these, and it's a multiple choice question, there can be multiple answers. Please rephrase the question. The question should be rephrased. Which of the following options is not a septal panniculitis associated with a medium vessel vasculitis? Okay. Which of these is not a septal panniculitis associated with a medium vessel vasculitis? Let's go to Kahoot. So please rephrase, because I think I've chosen the options according to that particular phrase of the question. And you can choose multiple. So which of these options that are going to come up are not an example of septal panniculitis with medium vessel vasculitis? And it's multi-select. There can be more than one option. Since these are double negative questions, I often get confused myself. So that's why I got confused in choosing the options. So the only answer here, the only correct answer for septal panniculitis with medium vessel vasculitis is polyarteritis nodosa. Okay. So therefore, all the others are wrong. And those are all the options that you need to choose. So erythema nodosum is a septal vasculitis, but it's not a septal panniculitis, but it's not a medium vessel vasculitis. I told you it's a small vessel vasculitis. It's a leukocytoclastic vasculitis. Erythema induratum is an example of a lobular panniculitis, and so is erythema nodosum neprosum. Okay. So these three are automatically excluded, and therefore these are the options you had to choose. Let's see how many of you have got the answer correct. So Maitri Patel is still leading, followed by Guna Balaji, NG18, Shilana, and Anmol Godara. Maitri Patel is back with the answer streak of 3. Well done. So yeah, sorry for the confusion, but I hope I've clarified it before you answered it. So let's explain. Polyarteritis nodosa affects the arterioles and arteries in the subcutaneous at the dermis subcutaneous junction. In early regions, you have perivascular, intramural, intraluminal leukocytoclasia. In later stages, lymphocytes and macrophages predominant. Pathology is confined to the vessel site, and there is no extravascular interstitial soft tissue granulomas. Okay, so often the pathology is confined to the vessel site, and that's how you differentiate polyarteritis nodosa from other septal panniculitis with medium vessel vasculitis, and I'll explain what the other example is. So in the biopsy, if you're seeing a medium vessel vasculitis and you're seeing an you have to first decide whether it's an artery or a vein. If it's a vein, consider thrombophlebitis. If it's associated with panniculitis, then you see whether there is, so it's an artery, you've decided it's an artery, and if there is associated panniculitis. If it's lobular, it's nodular vasculitis. If it's septal, it's PAN, and in PAN, it's often the inflammation is confined to the vicinity of the vessel. If there are associated neutrophils and suppression, then you need to think about id reactions and fungal granulomas, fungal panniculitis and vasculitis, etc. Okay. Now, the other example of septal panniculitis with medium vessel vasculitis is thrombophlebitis. Thrombophlebitis is also a medium vessel vasculitis. The vessel is a vein instead of an artery. Okay, so often thrombophlebitis is confused with PAN histologically, and I'll show you examples. And the other typical feature of PAN is skip lesions, and these are also present in giant cell arteritis. If you remember your basics when you read your basic pathology, skip lesions are typical of even not only PAN but also of giant cell arteritis. Okay, so see here, this is affected. This part of the vessel wall is affected, whereas this part of the vessel wall is not affected. Again, this part is affected by fibrinoid change. Can you make out the fibrinoid change here? This is called fibrinoid change of the vessel wall. Leukocytoclasis and neutrophils are also present, of course. Now, I mentioned it's difficult to differentiate vein from the artery sometimes. Now, we do that by doing an elastic Vallen-Giesen stain. When you do that, the internal elastic lamina is quite nicely visible. Though this is also present in the vein, it's not so thick. And the disruption of the internal elastic lamina is indication of the vessel wall being damaged in polyarteritis nodosa. So mostly septal. This is a flowchart of panniculitis. Then panniculitis, septal with vasculitis. If it's small vessels, then you're looking at leukocytoclastic vasculitis. If it's large vessels, if it's a vein, superficial thrombophlebitis. If it's an artery, it's polyarteritis nodosa. This is septal panniculitis. Now, if it's lobular panniculitis with vasculitis, if it's large vessel and an artery, it's erythema induratum. If it's small vessels, venues, it's erythema nodosum leprosum or neutrophilic lobular panniculitis associated with rheumatoid arthritis. This is all quite detailed. But then if you're listening to a lecture on vasculitis, of course, I'll be explaining some basics as well as some more complicated and detailed things. As long as you, the 15 questions that I'm discussing in the Kahoot, as long as you understand those, I think that's more than adequate. So don't get too fussed if you're not able to understand each and every point, especially the details. But this is an example of PN where the vessel, where the inflammation is confined to the vessel wall. Okay. Here is nodular vasculitis where there's a lobular panniculitis, and you see lots of granulomas as well. And then, yes, there's a nodular vasculitis here in the case of erythema induratum. See, this looks like the PAN case, septal panniculitis, secondary thrombophlebitis. There's often a thrombus in the middle of the vessel. And there is, again, secondary inflammation. So there is itis as well because of inflammation. And often you do need EVG stain to differentiate between them because the vein, especially in the legs, where both the entities are common, PAN and thrombophlebitis. On the legs, the veins become quite muscular and they can be quite difficult to differentiate from arteries. So the differential diagnosis of neutrophilic vasculitis, we briefly touched upon, also includes septic vasculitis. Now, how does septic vasculitis differ from leukocytoclastic vasculitis? In septic vasculitis, there is often absent or scant nuclear dust. Even though there are neutrophils, the nuclear dust is absent. So there is no leukocytoclasis. Therefore, it's just a septic vasculitis. The typical feature is thrombi in the lumina, though there is no fibrin in the walls. So fibrin in the walls and leukocytoclasis is typical of leukocytoclastic vasculitis. In septic vasculitis, there are thrombi, but no fibrin in the walls, neither is there any nuclear dust. Now, thrombi in lumina is also present in thrombotic vasculopathies. But there in thrombotic vasculopathy, there is no inflammation. So therefore, it's not an itis. It's a vasculopathy. So these are easy to understand, remember. So if there is only thrombin, but no inflammation, it's a thrombotic vasculopathy. If there is thrombin, so if there are thrombi with inflammation, but no signs of leukocytoclasis, it's likely to be a septic vasculitis. Having said that, even a septic vasculitis, I won't go into the detail because there's a question coming up. After that, I'll explain actually. Sorry about this. We'll explain that in a few slides. Now, lividovasculitis, there's often fibrin in the vessel wall and thrombin in the lumen, and no nuclear dust, though there can be neutrophils and lymphocytes in this case. There is fibrin and thrombin as in leukocytoclastic vasculitis, but there is no leukocytoclasis, again, in lividovasculitis, okay? It's an itis, but no clasis. That's how lividovascular vasculitis differs from leukocytoclastic vasculitis. How does it differ from septic vasculitis? Because there is fibrin. In septic, there is no fibrin. Similar in thrombotic vasculopathy, there is no fibrin in the vessel wall either. Okay. If you see predominant fibrin, that is lividovasculitis. So this brings us on to the next question, Kahoot. And that's why I didn't explain septic vasculitis. The pathogenesis of septic vasculitis includes, and this is a multiple choice question. The question is framed correctly. No mistakes here. So one is disseminated intravascular coagulation. The second option is direct vessel wall invasion by the microorganisms or their toxins. 3, it's an immune-mediated vasculitis. Or 4, there are septic emboli. Okay. So which of these is a part of the pathogenesis of septic vasculitis? It's multiple choice. There can be one or more answers that are correct. Which of these is correct? You can choose more than one option. Oh, there are only 10 seconds actually. You have to quickly choose. Be quick. Okay. Sorry for the less time. I didn't realize there were only 10 seconds. Okay. So actually all the answers are correct. Those of you who were thinking about this probably missed out on answering this. So the pathogen of septic vasculitis includes all the above. In some cases, it can be DIC, therefore a thrombotic vasculopathy. Can be present in septic vasculitis, along with direct invasion of vessel wall by microorganisms. There can be immune complex mediated vasculitis in septic vasculitis. There can be immune complexes formed, or they can be septic emboli. So you can have one or more of these features in septic vasculitis. So let's see what the leaderboard is looking like. Guna Balaji is on top, followed by Anmol, Maitri Patel, NG, 18, and Shankar. I'm seeing similar names. 100 Rad is back with an answer streak of 3. So those of you lagging behind, we've got 3 more questions to go. So, not to fret. So that's why I didn't answer septic emboli earlier, septic vasculitis earlier. So you can see marked necrosis of the upper epidermis in septic vasculitis. This is not a good picture. It's scanned from a textbook. I don't have a good case myself. You can see, thrombus within the vessel wall and inflammation around it. No leukocytoclasis. Okay. So we've discussed vasculitic. We've discussed the vasculitis. Now we have come to vasculopathy. Now, before I do that, I think we've got a slide on lividovasculitis. So livido, typical textbook description is you got fibrinoid vessel wall necrosis. Okay. Not much in the way of inflammation if you look at standard textbooks. But then there are authors who argue that lividovasculitis is not just a vasculopathy. There is true vasculitis wherein there is inflammation. There are various theories proposed to the etiopathogenesis of lividovasculopathy, which include local hypercoagulative factors, local defects in anticoagulant factors, etc. I won't go into the details right now, but essentially in lividovasculitis, you see fibrinoid vessel wall necrosis, which is a primary feature, with or without thrombin. You may see neutrophils, but no dust, and lymphocytes later in the course. Now, I'll explain this. This is a case, one of my own, where you see here some ulcerated lesions associated with typical atrophy blanche. Now, we all know clinically what atrophy blanche is. You see these ivory white, porcelain white, actually, scars, reticulate scars. And these are typical clinical, so it's a spotter of atrophy blanche or lividovasculopathy. Now, however, this is the histology of the same patient. I took a biopsy because there were ulcerated lesions and the patient was getting quite painful ulcerated lesions. Now, lividovasculopathy can cause ulcers, but they're not that frequent, but can cause it. Now, you see here the inflammation is both superficial as well as deep. Now, here you see typical fibrinoid vessel wall change. Not much in the way of inflammation. Fibrinoid necrosis vessel wall is seen. So this, so far, is following the textbooks. Again, here, even the deep dermis, fibrinoid vessel wall necrosis. Okay. Not much in the way of inflammation. But then, see here, a bit more infiltrate. These are around the eccrine glands, actually. These are eccrine glands. Fibrinoid vessel wall change. You're seeing that. A little more inflammation here. But then, this is another part of the epidermis. You're seeing much more inflammation here. Okay. So much more inflammation, both lymphocytes and some neutrophils here. Fibrinoid vessel wall change is, of course, present. See here, fibrinoid vessel wall change. You can see a hint of neutrophils as well here. But look at this. This is a deep vessel. Look at this vessel here. Let us go higher part. Clear cut leukocytoclasis. You're seeing leukocytoclasis here, nuclear dust. Majority of them lymphocytes, but some neutrophils are also present. So in this case, made me convinced that Ackermann was probably right in calling out livedo vasculopathy to not only being a vasculopathy, but also being an itis. But maybe there's an overlap. In some cases, you've got pure vasculopathy only. In some cases, you've got an itis as well. And there may be cases of, say, antiphospholipid syndrome, where it's purely a coagulation disorder. In some cases, it may be associated, APLS, as we know, may also be associated with immune complex mediated vasculitis, and therefore there may be an overlap of both livedo vasculopathy and itis. And this is a topic of debate, of course, but I've just put that up. Lymphocytic vasculitis and livedo vasculopathy, there's a report of 137 cases, and they report at least 30% of the cases having true lymphocytic vasculitis. Now, lymphocytic vasculitis I've just only briefly mentioned because it's a controversial topic. Some people believe that it's not a true vasculitis, though there have been reports of there being a true vasculitis wherein there is fibrinoid vessel wall necrosis in a case of lymphocytic vasculitis. So these are examples where you may see lymphocytic vasculitis. I'm not going to go into great detail, but then we now move on to the occlusive vasculopathies, which include mainly thrombotic disorders, systemic thrombotic disorders like APLS, antiphospholipid syndrome, DIC, TTP, protein C, STFC, warfarin, induced necrosis, cryoglobulinemia. And then you have purely vascular coagulopathies, which are not systemic, where the vessel walls are defective or believed to be defective, which include Dego's disease. But then Dego's, some people believe is a systemic disease because they believe it's a variant of systemic lupus erythematosus. So that's a bit controversial. But then you have a pure livedo vasculopathy, which, is not based on systemic factors. Then you have embolic occlusion, can be endogenous like tumor or cholesterol emboli or foreign bodies like hyaluronic acid. This is an example of DIC where you have just thrombi, no inflammation, no fibrin within the vessel walls, just thrombus within the vessel, the extravasate IBC as well. And here you see thrombus within the vessel, and because of the thrombosis, the vessel wall is occluded. You may see infarction of the epidermis. That's purpura fulminans in DIC. Now, this is an example of hyaline thrombi. It's not, you can differentiate this from a true IBC thrombus. This is a case of cryoglobulinemia. But cryoglobulinemia can also be associated with true leukocytoclastic vasculitis, and this is therefore an overlap of both thrombotic and leukocytoclastic vasculitis. So vasculitis is a very vast topic. You need to read about it, 3, 4, 5 times in the textbook. Read the pathogenesis as well for you to truly understand it. I'm only giving you an overview in the limited time we have. These are cholesterol emboli. The cholesterol gets dissolved in the process of in the processing, and you see these sort of stellate-shaped spaces. These are cholesterol emboli. This is tumor embolus. CD31 is used to mark the vessel wall, and these are tumor cells within the vessel wall. These are tumor emboli. Ecthyma granulosusum, you see a gram-negative Pseudomonas. These are the basophilic, the hue in the vessel wall is the Pseudomonas, actually, the bacteria. So we've got 3 questions back to back, I think, Kahoot. That finishes this lecture. The histological features seen in antiphospholipid syndrome include, now you have to use your brains here because I've already discussed most of this. So the histological features include thrombotic vasculopathy, no inflammation around the vessels, dermal necrosis, or is it all of the above? Okay. I think there's only one option, if I'm not wrong. So question number 13, we've got 2 more questions after this. I think lecture is more or less done. So thrombotic vasculopathy, no inflammation, dermal necrosis, or all of the above. Only one option. . Right. The correct answer was all of the above. I told you APLS, antiphospholipid syndrome, can present with a purely like a livedo pattern, a livedo vasculopathy pattern. So they can have just a thrombotic vasculopathy sometimes. There may be no inflammation, and because of the vasculopathy thrombosis, there may be dermal necrosis. Okay, so all of the above is the correct answer. Most of you have got the answer right. NG18 is moved up, followed by Dr. Shankar and Avi. Up 14 places, Sunita Mek is the highest climber. Let's go to the next question. So which of the following regarding vascular changes in Mucha-Haberman disease? I've not discussed this, but this is to sort of select the people who are studying from the people who are not. So this is not based on this lecture at all, but this is a googly question. Hope you know this, but even if you don't, I'll explain the answer, so don't worry. Which of the following is true? It's a true lymphocytic vasculitis. A true lymphocytic vasculitis has been described in Mucha-Haberman disease. Livedo vasculopathy is typically seen. There are no vascular changes. It is just an interface dermatitis. Of course, you need to know what Mucha-Haberman disease is. And then option number 4, leukocytoclastic vasculitis has been described. Okay, which of these is true? There's only one correct answer. Let's move to Kahoot for lack of time. Okay. Oh, it's multi-select. Sorry. So you can choose more than one. There you go. You can choose more than one correct answer. Multi-select. True lymphocytic vasculitis has been described. Livedo vasculopathy is typically seen. There are no vascular changes. It's just an interface dermatitis. Leukocytoclastic vasculitis has been described. So you can choose more than one answer. Right. The correct answer is actually leukocytoclastic vasculitis. Mucha-Haberman disease is acute pityriasis lichenoides acuta with ulceration. And leukocytoclastic vasculitis is what has been described in it. Lymphocytic vasculitis is not common in this. Livedo though it has been described. So it is also the correct answer, actually, sorry. So in though leukocytoclastic vasculitis is typical, lymphocytic vasculitis has also been described. So therefore, you've got 2 answers. Livedo vasculopathy is not seen. And yes, it is, though pityriasis lichenoides is a interface dermatitis. In Mucha-Haberman disease, both lymphocytic and leukocytoclastic vasculitis have been described, though leukocytoclastic vasculitis is more common. But yes, if you've answered both or one of them, you've got at least half of the answer right. Let's see what the leaderboard is looking like. So top 2 haven't changed. So Anmol and Dr. Shankar, you've got a chance to beat Dr. Gunabalaji. NG18 and 100 Rab, you've got a chance to go to the 2nd or 3rd position. I don't know what the 6th and 7th are like, but maybe you have a chance as well. With the last question coming up now. Oh, this is an example of pityriasis lichenoides showing lymphocytic vasculitis actually, but leukocytoclastic vasculitis has also been described. You can see fibrinoid vessel wall necrosis, lots of lymphocytes. I think there may be an occasional leukocyte here as well, actually. There's some nuclear dust here. Okay, so last question coming up. So here you're seeing vasculitis affecting the deep vessels and also superficial vessels. I'm not just showing the picture. There you go. Vasculitis affecting the deep vessel. Presence of vasculitis in the superficial and deep dermis is indicative of A, medium vessel vasculitis, B, infection-associated vasculitis, C, autoimmune vasculitis, or all of the above. Okay. Oops, sorry. We'll go to Kahoot. So 15 of 15, the presence of vasculitis in the superficial and deep dermis is indicative of only one correct answer: medium vessel vasculitis, infection-associated vasculitis, autoimmune vasculitis, or all of the above. I've already discussed this earlier, so it should be easy for you. Let's see who tops the quiz. All of the above is the correct answer. As I told you, when the superficial and deep dermis are affected, it indicates either medium vessel vasculitis or a systemic cause. And in that case, it can be the systemic cause, can be infection-associated or autoimmune vasculitis as well. All right. So, yes, thank you very much for listening to me. I'll go on to the leaderboard in a second. And if you have any questions, we'll answer that once we look at the leaderboard. Or should we answer that first so that people are still attentive? Let's see if we have any questions. I don't think so, actually. Can we get a PDF algorithm for diagnosis of vasculitis? This lecture will be available again. Hopefully, a recording of it will be available on the IIDVL website as well. So, yeah, so you can hopefully go through that. I haven't yet prepared an algorithm, but there are lots of papers with the algorithm already. But yes, my algorithm is slightly different from what has already been described in papers and textbooks. I've combined everything into a presentation. So if you want to go through the presentation again, you'll have a recording of it. So thank you very much. And we have a DermPath WhatsApp teaching group. If you wish to join, that's my number. You can ping me on with your name and your designation as well, please. So let's go on to the leaderboard now. Oops, sorry. There we go. So number 3 is 100 Rab. Unfortunately, we don't know your name. And number 2 is Gunabalaji. Well done, Gunabalaji. You'll be getting a consolation prize. And number 1 is Dr. Shankar. So the winners of the quiz, please message me. You've got my number anyway. So yeah, runner-up number 4 is Dr. Anmol and thing. Number 5 is Dr. Ravi. Well done, all of you. And those of you who participated, well done. It doesn't matter whether you win or not, because I hope you've learned a lot from the quiz. And yes, please give your feedback as well for the quiz. It'd be very helpful for future quizzes. Now, this is the last in the series of 6 quizzes we have for this academic year. Hopefully, we'll be back in a couple of months with the next series of quiz-based lectures. And we'll get back to you on this. Thank you very much. Over to Dr. Geeti to take over. Dr. Geeti, are you still there? Oh, maybe she's left. I'd like to thank Glodama as well for helping us or sponsoring us with this lecture. And on to the Glodama technical team, if you have anything to add.
Yes, sir. Thank you so much, all of you. And thank you to DSI and Dr. Sasi, sir, to giving this opportunity to Gloderma. Gloderma, always thank you to all of you. Kindly support and thank you, all of you. Thank you.
Thank you very much for joining. Goodbye.